Hello everyone, welcome back to my channel. Today we will be learning GIT Pathology. In this chapter we will be dealing only with the pathology of the GIT. The physiology of the GIT will be dealt in some another videos. Now here we will start by esophagus. The esophagus, its length is about 25 to 30 centimeter. There will be presence of airbox plexus and the Meissner plexus are absent in this part. There will be absence of serosal layer. As we all know that in this esophagus, there will be presence of adventitia layer. Now, there is another important disease known as the Mallory-Weiss syndrome. In this Mallory-Weiss syndrome, it has a non-transmural longitudinal tear. Means here the tear will be longitudinal, not transverse, at the gastroesophageal region. Means where there is ending of esophageal and the starting of the gastric region. In that region there will be tear. That will be longitudinal tear. Coming to the etiology of this disease, it is severe or vigorous retching or vomiting can be seen. The clinical features of this disease are hematemesis, that it healing appears rapidly and it is complete. The important note here can be seen are what are the causes of the hematemesis. The causes of hematemesis can be Mallory-Weiss syndrome as we discussed now, esophageal varices, reflux esophagitis or esophageal ulcer. Coming to next topic, that is Barrett's esophagus. Barrett's esophagus is an important question. Now here we can see that it has intestinal metaplasia. Intestinal metaplasia and the complication leads to GRD. 10% of the patients can be seen with Barrett's esophagus, that is mostly males of around age 40 to 60 years. Coming to microscopy of this Barrett's esophagus, as we have discussed, there is intestinal metaplasia, that is the conversion of squamous lining can be seen into columnar mucosa. The most important hallmark of this Barrett's esophagus is the goblet cells are present. And this intestinal metaplasia can lead to important risk of adenocarcinoma. Another important feature of this Barrett's esophagus in microscopy can be seen is dysplasia. Next, esophageal carcinoma. Esophageal carcinoma is of two types, that is squamous cell carcinoma and adenocarcinoma. Coming to squamous cell carcinoma, the main etiology can be alcohol intake, tobacco, nutrition, hot beverages. Plummer-Vinson syndrome. This Plummer-Vinson syndrome is a triad and it is an important question. That is, the triad is of iron deficiency anemia, esophageal webs and glossitis. Next, achalasia cardia, celiac diseases, HPV infection. Coming to morphology of this esophageal carcinoma is, it is middle third of the esophagus. It is fungating or exophytic. It is ulcerative. It is infiltrating or stenotic. How does this carcinoma spread? The carcinoma of this esophageal can be spread by three parts or three ways. That is, it can spread through local spread or lymphatic spread or hematogenous spread. Now, the next is adenocarcinoma. Adenocarcinoma can be of two, that is Barrett's esophagus or long-standing GRD, that is gastroesophageal reflux disease. Coming to its etiology, it can be of dysplasia, tobacco, obesity, and scleroderma. Now, pathogenesis of this adenocarcinoma is genetic mutation of p53, amplification of ERBB2 and cyclin D1 gene. Now, epigenetic pathogenesis can be, it is a silencing by hypermethylation of P16 or INK4A gene. Clinical features of this adenocarcinoma are pain can be seen, difficulty in swallowing, chest pain. Important note to be remembered here is when we do the barium swallow, when we give the barium compound to inhale for the patient, after that barium swallow test in the esophageal cancer rat tail appearance is seen in this individual? It is an important question for NEET PG or an MBBS second year student. Now, we have completed the esophagus. Now, let's move to the next part, that is stomach. In stomach, the main important part is gastritis. What is gastritis? As we all know that when it is come to it is, that is, it is inflammation of the gastric mucosa. In inflammation, we can see that there is a presence of neutrophil above the basement membrane. So this gastritis can be divided into acute gastritis. In this acute gastritis, we can see there is a transient inflammation of the gastric mucosa. The etiology of this acute gastritis can be drugs, H. pylori, alcohol, chemical, bile reflux, or viral infections. Coming to pathogenesis of this gastritis, it may be disruption of any protective mechanism or decrease in the synthesis of mucin and bicarbonate secretion. There may be gastric injury by H. pylori. There may be ingestion of any chemicals, insufficient epithelial regeneration, or maybe there will be decrease in the O2 supply. As we have seen the acute gastritis, now coming to chronic gastritis. In this chronic gastritis, there will be inflammation of the stomach associated with the mucosal injury. There will be increase in the inflammatory cells in the lamina propria. This is an important part. Now, there will be similar as the H. pylori infection, autoimmune gastritis, radiation injury. The important organism is H. pylori as it causes both acute and chronic gastritis. It is tested by Giemsa stain or Warthin-Starry stain in microbiology. By using these two stains, we can see H. pylori. H. pylori, it produces urease. It is non-invasive. It colonizes in the mucosal layer. It causes intestinal metaplasia, which is the precursor of the gastric cancer. H. pylori gastritis means the gastritis caused by H. pylori. It is intraepithelial. Neutrophils can be seen in this gastritis. In subthelial plasma cells, superficial lamina propria also we can see. H. pylori causes increased risk of gastric adenocarcinoma and gastric malt lymphoma. Biochemical test positive for this H. pylori, we can remember by the mnemonic cow. That is catalase, oxidase, and urease by COU. Therefore, it is known as cow. Culture media. This H. pylori can be seen in Skirrow media and in chocolate media. The next important part is peptic ulcer disease. Peptic ulcer disease means it is a mucosal defect that is at least of 0 to 5 centimeter in diameter, which penetrates the muscularis mucosa. Normally in stomach, we can see that there may be of two forces, that is the damaging forces. The damaging forces we can see gastric acidity, peptic enzymes, and the defensive forces. The defensive forces are of preepithelial, epithelial, and subepithelial. In preepithelial, we can see there is a surface mucus secretion, bicarbonate secretion. In epithelial, we can see that there will be regenerative capacity, prostaglandin. In subepithelial, we can see submucosal blood flow, leukocytes. Damaging forces, direct mucosal damage can be seen by H. pylori infection, NSAIDs like aspirin, ibuprofen, etc., cigarette smoking, alcohol, hyperacidity. Impaired defensive forces are ischemia, shock, delayed gastric emptying, host factors. Now, here we can see the prostaglandins protect the gastric mucosa by increasing the secretion of bicarbonates, increasing the vascular perfusion, or inhibiting the acid secretion, or increasing the synthesis of the mucin. Coming to pathogenesis of this peptic ulcer disease, we can see the risk factors of H. pylori infection. That is, the H. pylori infection causes this disease. That is, it can be seen in 90% of the duodenal ulcers and 65% of the gastric ulcers. Coming to the risk factors, it may be of cigarette smoking, NSAIDs, COPD, alcoholic cirrhosis, psychological stress, Zollinger-Ellison syndrome. This Zollinger-Ellison syndrome is important. It is dealt in the upcoming part in the next video. It may be of two types, that is a direct mucosal injury and impaired defense. In impaired defense, we can see that it may be of ischemia, shock, or delayed gastric emptying. There is an important note here to be noted, that is kissing ulcers. What is meant by kissing ulcers means this is the part of the duodenum. In duodenum, we can see in anterior part there will be an ulcer, and in posterior part there will be an ulcer. The ulcer is formed in such a way that they meet in such a way that the kissing ulcer pattern is seen. Hence, the peptic ulcers occurring at both posterior and anterior wall of the duodenum are known as kissing ulcers. Coming to microscopy of this POD, we can see here 4 layers. These 4 layers are known as Ascanzi zones. First zone is a necrotic zone, superficial exudative zone where there will be presence of neutrophil infiltrate, granulation tissue zone, and zone of citization, zone of citrization. Now, the complications of PUD are first bleeding, perforation, pyloric obstruction, malignant transformation. Note, when there will be bleeding in the part, it may be due to when there is bleeding in the duodenal ulcer, it is mainly due to gastroduodenal artery. And if there is bleeding in the gastric ulcer, it is due to left gastric artery. Please note, these are the important arteries which causes bleeding in the respective ulcers. As I mentioned before, this Zollinger-Ellison syndrome, which is known as ZES, it is the triad. We should remember the triad by the triad. It comprises of first one is hypergastrinemia, which it causes increase in the acid production, which leads to severe peptic disease. We can remember this by as the gastric secreting tumors increases, they produce massive acid production. This acid production leads to hyperacidity. This hyperacidity causes single or multiple ulcers. Gastric adenocarcinoma. This gastric adenocarcinoma is the most important or most common malignancy of the stomach. In antrum, we can see the gastric carcinoma of lymphoma, and in fundus, we can see gastric carcinoma in pernicious anemia or diffuse type of gastric carcinoma. The difference between epithelial tumors and mesenchymal tumors, it is premalignant lesions, intraepithelial neoplasia or adenoma, leiomyoma, adenocarcinoma, schwannoma, papillary adenocarcinoma, granular cell tumors, tubular adenocarcinoma, leiomyosarcoma, mucinous adenocarcinoma, GIST, signet ring carcinoma, Kaposi carcinoma, undifferentiated carcinoma, others, adenosquamous carcinoma, neuroendocrine neoplasms, malignant lymphoma, carcinoid tumors. These are the different types of epithelial and mesenchymal tumors in the gastric adenocarcinoma. Now coming to, it may metastasize to the periumbilical lymph node and forms subcutaneous node. This node is known as Mary Joseph nodule, or it may metastasize to ovaries. It is known as Krukenberg tumors. Blood spread, it may take to portal veins and next to liver, lungs and bones are affected. Clinical features of this disease is high risk areas, that is intestinal type gastric cancer may arise from precursor lesions. Advanced cancer, Trocher's sign can be seen. This Trocher's sign means in gastric carcinoma, Virchow's left supraclavicular lymph node involvement due to metastasis. This is known as Trocher's sign. Trocher's sign, it is a non-metastatic effect, maybe in the form of migrating thrombophlebitis and deep vein thrombosis. Now, coming to gastrointestinal stromal tumor. It arises from the intestinal cells of Cahal. These intestinal cells of Cahal are the pacemaker of the gut peristalsis. It is similar to those cells like SA node in the heart, which initiate the electropotential. Now, the most common mesenchymal tumor of abdomen. It is most common located in the stomach. It is mainly seen in the males. Infection with H. pylori is associated with the distal intestinal type of gastric carcinoma and not with the proximal carcinoma. Gastric carcinoma, here the important tumor markers are CEA, CA 19.9, CA 125, CA 72.4, BHCG. The important triad here we can see is Carney's triad. The Carney's triad, it is mainly seen in young females. The triad comprises of gastric GIST, paraganglioma, and pulmonary chondroma. The pathogenesis of this is there is mutation of gene encoding tyrosine kinase. Then there will be activation of KIT or platelet-derived growth factor receptor alpha. This leads to intracellular signals. These intracellular signals activate RAS and PI3K or AKT pathways. Then this promotes tumor cell proliferation and survival. Now coming to clinical features. The clinical features are mucosal ulceration. In mucosal ulceration, we can see there is a blood loss and CT scan and PET scan can be done. Now coming to prognosis, the prognosis of 3, that is tumor size. Metastasis rarely occurs when the size is less than 5 cm. It may be mitotic index or location. GIT, gastric GIST is less aggressive than small intestine. Now, the next part is Meckel's diverticulum. This Meckel's diverticulum, the symptom mimics like acute appendicitis. The rules of 2S are most important in this Meckel's diverticulum. It can be asked in NEET PG also. The rules of 2S comprises that it occurs in 2% of population. It occurs 2 feet below the ileocecal valve. It is of 2 inches long, 2 times common in males, and symptomatic by age of 2. Now, complications of this Meckel's diverticulum is it can be bleeding, severe hemorrhage. Meckel's diverticulum leads to secondary peptic ulcers, intestinal obstructions. Now, the next important part is typhoid fever. This typhoid fever, that is ingestion of contaminated food and water. It is mainly due to Salmonella typhi, survive in the gastric acid of the stomach. Then in ileum, it penetrates mucosa and phagocytized by mononuclear phagocytes in the Peyer's patches. Then it reaches mesenteric lymph nodes and multiply. Then it is carried throughout the lymphatic system and blood streams. Then it colonizes reticuloendothelial tissues like spleen, liver, etc. There it multiplies in the gallbladder. It is discharged into the intestine where it involves Peyer patches of the small intestine. Coming to intestinal tuberculosis, in this intestinal tuberculosis, it is mainly of terminal ileum, then ileocecal junction. The difference between tuberculosis and typhoid ulcer, the site is small intestine, it can be anywhere. Orientation is longitudinal in long axis, it may be transverse in long axis. In microscopy, we can see macrophages and lymphocytes and plasma cells. Here, granulomas composed of central area caseous necrosis, epithelioid cells, Langerhans giant cells, and lymphocytes. Coming to differential count, neutropenia, lymphocytosis. Perforation, it is common as acute process associated with the thinning of the bowel wall, not seen because chronic inflammation results in healing by fibrosis. Hemorrhage, it is most common. Here hemorrhage doesn't occur. Obstruction not seen. Stricture formation leads to obstruction. Extraintestinal may develop carrier state, may develop tuberculosis, peritonitis. Coming to shigellosis. Shigellosis is bacillary dysentery. The bacillary dysentery is superficial ulcers with infiltration of the neutrophils. This bacillary dysentery is necrotizing infection of distal small bowel and colon by the Shigella. This Shigella you have learnt in the microbiology. It is an important organism which causes bacillary dysentery. Coming to ulcers, it may be continuous, diffuse, and most prominent in the left colon. Now, we will stop here. The remaining GIT will be continued in the part 2 video that will be uploaded soon. Please like our content, please share it, and please subscribe to our channel for more such videos which may help you in MBBS or in NEET PG.